None of the producers have any financial interest in the products or procedures shown. Extrusion Cannula Assisted Levitation, ECAL. The capsular bag is by far the most important structure in cataract surgery, as it holds the intraocular lens in place postoperatively. Yet at times, we as surgeons undergo hardships by dropping the intraocular lens on table or a few days into surgery. Dislocated IOL could also result from external trauma, ND-YAG capsulotomy, or internal forces like zonular weakness and progressive conditions such as Marfan syndrome, pseudoexfoliation, and many other conditions. Is it safe to leave behind the intraocular lens in the vitreous? No. Leaving an IOL in the vitreous can cause vitritis, fibrosis, endophthalmitis, cystoid macular edema, vitreous hemorrhage, retinal tears, retinal detachment, epimacular membrane, high intraocular pressure, all of which can lead to a loss of visual acuity. Also, if the IOL stays in front of the fovea, it has been reported to cause a disturbance in vision. Let's look at the procedure and its variations followed currently for dropped intraocular lens IOL management. Step 1. Vitrectomy to remove all adhesions around the intraocular lens. Step 2. Intraocular lens IOL lifting forceps are used, where the forceps is brought perpendicular to the intraocular lens haptic, which is then carefully lifted from the retina. In certain cases, we could use PFCL to help create space between the IOL and the retina. Step 3. Option 1. In case of a 3-piece IOL, it can be immediately repositioned into the sulcus or glued into place. Option 2. In case of any other IOL design or broken IOL, the only option would be to explant the IOL out of the eye and replace a new IOL with an IOL implantation technique of your choice. Let's look at the fears, risks, or complications in this form of management. Proximity of the forceps to the retina. To demonstrate this with the help of an experiment, we are using a fluorescent strip representing the retina, a drop of water representing the touch of the instrument to the retina, IOL lifting forceps, extrusion cannula, and a plate haptic lens. Experiment 1. Simulation of proximity of the forceps while lifting the IOL. Using the forceps with a drop of water, it stains the fluorescent strip. Experiment 2. Simulation of difficulty on lifting IOL from the retina, struggling in lifting the IOL. As shown in this experiment, the pinching mechanism of the forceps brings to this form of management a high risk of injury to the retinal layers in the form of edema, hole, tear, or haemorrhages. The forceps enters the eye through the pars plana and approaches the IOL lying on the floor of the retina, hence in a perpendicular fashion. Now, as the action of the IOL lifting forceps is to pinch, there is no space to grab a part of the IOL at its shortest diameter, especially in plate haptic IOL. Perfluorocarbon liquid PFCL can lead to striate keratopathy postoperatively. How do we prevent these complications? We have an answer. The Extrusion Cannula Assisted Levitation Technique. The extrusion cannula is a long, blunt needle with a silicone tip and an internally catheterized silicone body. It has been used by many of the retinal surgeons in retinal detachment surgery to drain subretinal fluid via a retinotomy. The concept of ECAL is to use a suction device in lifting the IOL from the retina, eliminating any risk, fear, or complication shown earlier in this video. We use the extrusion cannula without its silicone tip, as this increases the surface area for the grab or occlusion to the IOL and prevents any IOL dangling caused by the silicone tip. Procedure for the ECAL. Step 1. Vitrectomy is done to remove all adhesions from the IOL to prevent any suction being applied to the vitreous. Step 2. Settings on vitrectomy 300 to 400 mm mercury vacuum. Step 3. Extrusion cannula is inserted into eye and the IOL approached as shown, keeping in mind not to press the suction foot pedal. Step 4. As soon as you adhere to the IOL surface, press the foot pedal down. Step 5. Lift the IOL out through the pupillary zone, grab the anterior haptic with glued IOL forceps, and with a bimanual technique either reposition the IOL into sulcus or exchange the IOL with one of your choice like anterior chamber IOL, scleral fixated IOL, or glued IOL. Comparative experiment of IOL lifting forceps levitation to extrusion cannula assisted levitation. In this experiment, if the drop of water touches the fluorescent strip, it represents a retinal touch. Now, using the IOL lifting forceps, we see most attempts resulting in a retinal touch, while the extrusion cannula never touches the fluorescent strip, hence showing the safety and accuracy of the ECAL procedure. A second experiment shows the difficulty in lifting the IOL using IOL lifting forceps due to the perpendicular pars plana approach versus the ease of lifting the IOL using the same pars plana approach in our ECAL procedure. A vertical pars plana approach creates this difficulty in lifting the IOL off the retina. Unfortunately, we have no way of approaching this IOL horizontally as shown in this third experiment. Tips and tricks for ECAL. Tip 1. Maintain vacuum of 300 to 400 mm mercury. Tip 2. Not to press the foot pedal until we adhere to the IOL optic. Tip 3. If the distance from the extrusion cannula grab or occlusion to the superior haptic tip is more, then the chances of the haptic touching the iris is high, and hence the chance of suction loss is more and the IOL drops back into the eye. To prevent this problem, we must grab the IOL in such a way that the distance from site of extrusion cannula occlusion to the superior haptic is less, and the haptic can be brought into pupillary zone with minimal amount of pronation to the wrist. It has been published before in February 7, 2014 in the British Journal of Ophthalmology and is also being followed in a lot of practices. To conclude, any vitreoretinal procedure requires intervention by a trained specialist and referral is often indicated and should be done for such cases. If not managed properly, a dropped IOL can cause problems like inflammation, hemorrhage, retinal tears, cystoid macular edema, etc. However, the anterior segment surgeon should be aware of the various management options in such complicated cases, and that is exactly what this video aims to do.